Okay, and we are live. So, welcome everyone, and thank you for joining us for another session of frequently asked questions on multiple myeloma following relapse after 3 or more lines of therapy. I'm Mary DeRome, Senior Director of Medical Communications and Education at the Multiple Myeloma Research Foundation. Today, I am joined by Dr. Nitya Nathwani and nurse Jennifer Bautista from the City of Hope Medical Center in Duarte, California, and also Miss Janet Anderson, who is a patient from Lake Forest, California. We've invited them here to answer questions about patients who have previously received multiple prior lines of therapy. So, Dr. Nathwani, I'm going to start with you and welcome to our broadcast, and thank you for being with us today. We really appreciate it. So, Dr. Nathwani, how many patients relapse from having received many patients relapse from having received many different treatments, depending on how many times they've relapsed, right? So, how do you know which drug or drugs the patient has received, which is no longer working when they relapse, and they may be receiving a combination of drugs? Or is it usually all of the drugs that they no longer respond to?
So, one of the key things is multiple myeloma is not one disease, but a spectrum of disease. And we know that multiple relapses can occur, but fortunately, we have many therapies now that we can employ along the way in the course of a patient's myeloma journey. There's this idea of clonal evolution. So, the myeloma that you start out with is not necessarily the myeloma you end up with, meaning patients acquire genetic abnormalities in their myeloma cells. Sometimes it may be that one clone of myeloma is more sensitive to certain drugs versus another. So we're able to eradicate that clone, but a different clone subsequently surfaces. And in part because of this nature of multiple clones in a different patient, we often use multiple drugs as treatment, both in the newly diagnosed setting as well as the relapse setting. And since it's difficult to know specifically which drug is not working, we want to attack the myeloma cells in many different ways and try to prevent them from becoming resistant to treatment. So we tend to switch around the different classes and agents at the time of a relapse.
So, Jennifer, many patients ask about which tests should patients follow to be aware of potential disease recurrence. So, for example, should patients be watching their light chain values, or is it the M protein, or is it something else that patients should be watching to really tell whether or not they're relapsing? And of course, they would talk to their doctor as well, obviously.
So the SPEP is the main test that we use to find out how much myeloma protein there is. And those results are called the monoclonal protein, or M spike, or M protein. Around 20% of patients do not produce intact proteins and will only produce free light chains. Mm-hmm. These patients are said to have light chain myeloma. Mm-hmm. There is a specialized test called the serum free light assay, which quantifies this. And these are the two most commonly used tests to routinely monitor for disease recurrence.
Mm-hmm. Do you find when you're talking to patients about lab values and what they might mean, are patients familiar with what you're talking about? Do they understand the types of measurements that you're taking and what you're measuring? Or is it something that patients kind of have difficulty with?
It depends on which part of the disease progression that they're in. Mm-hmm. Early on, they are not very familiar, but that's the time when I can break it down and explain to them what type of light chain myeloma we're categorizing them under and what labs to look for at that point.
Mm-hmm. Mm-hmm. I suppose that as you move towards multiple relapses, you become more and more familiar with the disease.
Correct.
So that makes sense, yeah. So, Dr. Nathwani, at what point in a patient's treatment course is a change in treatment warranted? Is it when patients are not responding to a course of treatment, or if in their course of having their labs done, you see increasing M protein after a response?
So we generally change treatment when it's not working, obviously. And, this can be a lack of response from the very beginning, or an increase in the M protein or involved light chains after an initial response. So, in other words, if the M protein or the involved light chains increase by more than a certain amount, we would need to change treatment.
Mhm.
Now, this could be within the first month or two after starting a new treatment, or the M protein could rise 5 years after being on a given treatment. So, one of the important things to keep in mind is there has to be a clear increase that meets a certain minimum threshold in order to warrant changing treatment. So, for example, usually if the M protein increases by more than 25%, and that increase is confirmed on a second reading, we
Mhm.
will change treatment. There are also specific criteria for light chains as well.
Mhm.
Another important thing to keep in mind is that we need to give the treatment enough time to start working, and we usually want to wait a few weeks from the time we start a new treatment before we say it's not working. And also, some treatments can take longer to achieve their full potential.
Mhm. Mhm. So Janet, let's go to you now and talk to you a little bit about your disease journey. So how did you find out that you had a relapse? Was it through a lab test, a blood test, or did you feel any specific symptoms when you relapsed? So could you tell even before you went to the doctor that you were relapsing?
No, I mean, up to this point, I've never had any actual physical symptoms. I check the City of Hope patient portal and I look at my kappa light chains. I don't have an M spike, I have the kappa light chain myeloma.
Mhm.
And so thankfully, I've not had any actual symptoms or
Mhm.
pains.
Mhm. Mhm. So it was really the whole lab test thing that really sort of
Yes, yes.
tipped you
And
off.
they test my light chains every month. And
Right.
so I would watch them in the beginning, the first couple of lines of treatment, increases would just creep. And as I got further along with third and fourth therapies, I'd see a lot bigger
Mhm.
jumps.
Mhm. So, Dr. Nathwani, what does cause a patient to relapse? Whether it's their first relapse or their third or fourth or fifth line of prior therapy, does relapse have anything to do with chromosomal abnormalities or any other characteristics that a patient might have?
So generally what we do see is, the first remission is the longest, and, after each subsequent relapse, the duration of response seems to be shorter. But with some of the newer therapies, which we are very excited about, we are now getting longer remissions, even in patients getting therapies in the fifth line and beyond. So, why is the disease different at each stage? So, some of this is this idea of clonal evolution that I talked about earlier, meaning patients acquire genetic abnormalities in their myeloma cells that can potentially make the myeloma more aggressive as it starts to come back. The chromosomal abnormalities are one of the important determinants of relapse. For example, patients that have so called high risk myeloma have very specific chromosomal abnormalities that occur inside their plasma cells. This is not something they're born with, it's acquired over time. And for patients with high risk myeloma, the response to each line of treatments tends to be shorter than in patients with standard risk myeloma who do not have these specific genetic abnormalities. The good news is that with the newer treatments, we are seeing significant improvements in outcomes.
Mhm. Mhm. We do have a lot of that good news in the myeloma community these days, right? With all the new therapies we've got, which is really great. So, Jennifer, when you're talking to patients about their disease, what do patients need to know about their cytogenetic test results? So, I know that these results can be confusing for some patients, and they don't really understand what they mean. So, when you're talking to the patients, how do you help them process this information, um, and why it's useful in discussing treatment plans?
Great question. Um, Cytogenetic test results are difficult to interpret. I would advise the patients to ensure that FISH testing has been performed at diagnosis and to discuss these results with the treating team.
Mhm. Do you guys at City of Hope do anything really beyond that? Are you doing any sort of next generation sequencing or anything like that?
We are actually.
Good.
Mhm.
A lot of information there. So Janet, are you aware, and do you know if you have any cytogenetic abnormalities in your myeloma?
Yes, I have a lot. I started out with 17p deletion and then picked up gain of 1q and monosomy 13 as more relapses came.
Mm-hmm.
And although not a cytogenetic abnormality, I do now have extramedullary disease where the myeloma now has figured out how to grow outside of the bone marrow. So that's another high risk factor.
Yeah, yeah. Dr. Nathwani, do any therapies exist for relapsed and refractory patients who have specific chromosomal abnormalities or are patients who are considered to be high risk? And can you tell us what those are?
Sure, absolutely. So that's a great question. There is an ongoing coordinated effort to provide targeted therapy for specific chromosomal abnormalities. And as you know, this is being done through the Multiple Myeloma Research Consortium, the MMRC, in a study called MyDrug. So let me tell you how this works. So first, we perform genomic sequencing of the cancer cells in the bone marrow. If there's a specific therapy that exists for a certain chromosomal abnormality, then that specific therapy is given in combination with standard myeloma therapies. So I'd like to highlight a subset of myeloma patients who have a very specific abnormality called translocation 1114. And what this means is a piece of chromosome number 11 breaks off and gets reattached to chromosome 14. It's not actually that uncommon. It probably occurs in somewhere between 15 and 20% of myeloma patients. And there is some data to suggest that standard treatment may be a bit less effective in this subset of patients. The good news is that there is a medication called venetoclax, which is a pill that's very effective in this specific subset of myeloma patients with this chromosomal abnormality. And while it's not approved in multiple myeloma, it has been approved in other blood cancers.
Mm-hmm.
We have another clinical trial at our institution that specifically targets this 1114 translocation with another agent as well. So, you know, um, targeted treatment is becoming more and more common, and it's really establishing the role of precision medicine in myeloma.
Mm-hmm. Mm-hmm. So yeah, that's great. And I know that venetoclax is actually involved in the MyDrug trial, right? And so I think that at this point, I mean, we've been waiting for this drug to be approved in multiple myeloma for quite some time. And I think we may actually see that happen perhaps in the next year. That would be great because we all know how effective it is for that particular subset of patients. That would be excellent.
Absolutely.
So, Jennifer, some patients might not have a lasting response after a stem cell treatment. As Dr. Nathwani was saying, usually after patients who are eligible have a stem cell transplant and then they have consolidation and maintenance therapy, that can normally be their longest ever period of being disease free before they relapse again. So what does it mean? Does that mean that a future transplant would be unsuccessful and would not be an option at relapse if they didn't really respond to the first stem cell transplant? And I don't know how common it is really to have more than one stem cell transplant, but I know that there are patients who are particularly high risk that do undergo stem cell transplant more than once.
Twice, correct. Well, Mary, that's a hard question, as this is an individual decision depending on the duration of the response to the first transplant and the available treatment options for an individual patient. So in general, we say that the duration of a response to a second transplant is approximately half the duration of response to the first transplant.
So, I mean, normally I know patients usually when they undergo their first stem cell transplant, they have enough stem cells collected to be able to do at least one more and sometimes two more, depending on how successful the collection is. So, and certainly if you have all those cells stored, even like in later sections of your disease, when you're having trouble with your blood counts, et cetera, they will take those stem cells and reinfuse them back into patients in the absence of, having a stem cell transplant, just to get blood counts to come back up. So it's actually like a really good resource for patients if they can collect a lot of those cells. So Janet, what can you tell us about your treatment journey? For example, what was your initial treatment and what have you been treated with since your diagnosis? And I know that you've been through quite a number of things.
Yeah, so I've had myeloma for about 8.5 years, and I've had 5 different lines of treatment up to this point. So my first treatment, I didn't have an upfront stem cell transplant. When we found out I was high risk with a 17p deletion, Dr. Nathwani enrolled me in a clinical trial for newly diagnosed high-risk patients, and that was elotuzumab, which they now call implicit, plus Revlimid, Velcade, and Dex. And I did get about a 4.5 year remission from that. And then when I relapsed, we went ahead and did the stem cell transplant, followed up with Revlimid, Velcade, maintenance after 60 days. And that lasted 2.5 years. And then when I relapsed from that, I went on to my third line of therapy, which was one of the clinical trials for one of the BiTE drugs, the bispecific T-cell engager. And I was in the arm with talquetamab plus daratumumab, Pomalyst, and Dex. So that was a lot of drugs. That remission only lasted about 9 months. And it was at this time I noticed that my light chains were really going up dramatically. So, obviously I had the clone change like Dr. Nathwani was talking about. And so after that relapse, I went on my 4th line of treatment, which was Cytoxan, carfilzomib, and Dex. And that remission only lasted about 4 months when my numbers started going up. So, I've always responded to treatment, thankfully, but, I definitely could see the trend that my remissions were getting shorter and shorter. And where do you go after your last one's only been 4 months?
I know,
I was feeling like the curtains were starting to close. But then that's when Dr. Nathwani called me. It's like an angel of mercy and was able to get me into the CAR-T Abecma therapy. So I had my T cells collected around the end of July and received them back middle of September of this year.
Wow. Wow, that's great.
And doing great, in remission. I guess, can I say a complete remission? I mean, my numbers are low. My PET scan was good. So life is good right now. Good
for you. So that's like, being able to get one of these CAR-Ts is like winning the lottery. So
oh my goodness.
They're extremely effective drugs, but it's really hard to get on the list, and you have to be, and it takes a long time to make them once the cells are collected. So it's just, it's a very effective therapy, but it's not without its issues. So,
and it was good that, with Abecma, there were no hangups in the manufacturing of it. It was pretty much on schedule. And I know that's not necessarily the situation with other with the Carvykti.
Yep, that's true. So we'll talk some more about that. So Dr. Nathwani, we now have 3 different agents available that target the B cell maturation antigen, or BCMA. Abecma is one of those, right? And although you said you had talquetamab, Janet,
yes.
Right? Which
that's not BCMA.
That does not target BCMA, right? So it's actually good you had that.
Something 5 in there.
Right. So we just came back from the ASH meeting in New Orleans, and there was a big talk on that, which was really quite interesting. So okay, getting back to BCMA. So there's 2 CAR T therapies, Abecma and Carvykti, that are associated with the BCMA. And then there's another bispecific antibody, which is Tecvayli, which was just recently approved. So a common question we get is, what's the difference between those agents and how do you choose which one to get? And that sequencing is also a very big issue as well.
Yeah, so, very good question. I'll do my best to, answer it stepwise. So I think the good news for patients to remember is that all three products are incredibly effective, and we are seeing durable responses in a majority of patients who have received multiple prior lines of treatment. On average, these patients in the clinical trials had received 6 prior lines of treatment. So as Jen, said, there are a lot of factors to consider while deciding on, which treatment. So let me go through this a bit more. So CAR T cells use a patient's own T cells, which is part of the immune system, and these T cells are manipulated in the lab to kill myeloma cells. They are then infused in a patient in a very controlled manner. These CAR T cells are incredibly effective, and another very appealing aspect is it's given once, followed by a long treatment free interval, hopefully, a long treatment free
Hopefully.
interval, depending on
Mhm,
how long they work for.
mhm,
But the challenge is that CAR T cells, as you talked about, are harder to get. You have to be on a wait list to get this, and it takes a while to manufacture the cells in the lab. So, if a patient has very aggressive myeloma, it may not be practical to wait for this treatment. In terms of deciding between the two FDA approved CAR T cell products, I would say, they're both very active. And if a patient is eligible, we give either product. We'll often decide depending on which is available sooner.
mhm,
Another part of the message we're trying to get out to the referring doctors and patients and their caregivers is that if there is a patient with relapsed myeloma, it makes sense for them to be referred to a CAR T cell center early. While they may not be ready for CAR T cells, at least they get in the system.
yeah,
We're aware of them so
mhm,
that, when they need it, hopefully they're already on the list and we're able to move quicker to get them to therapy.
mhm, mhm,
Moving on to the bispecifics, these have two targets. One half of the antibody recognizes the target on the myeloma cell, and the other half of the antibody recognizes a receptor on the T cells. So this antibody grabs the T cell with one arm, grabs the myeloma cell with the other arm, pulls them together, and activates the T cell in the process so that the T cell can kill the myeloma cell. So teclistamab or Tecvayli is an off-the-shelf treatment. No need to wait for this long process of genetic engineering that's required with CAR T cells. So it offers a very active option to many more patients.
mhm,
The disadvantage of this medication is that it's given weekly, and with continued treatment, the risk of infections appears to be higher as
yeah,
this treatment depletes
mhm,
B cells,
yeah,
which helps with immunity to infections.
mhm,
So, that's a lot of information. And, to summarize that, I would say all three treatments that are targeting BCMA, both CAR T cells and the approved bispecific, are all very effective.
mhm,
It's an individualized decision. We consider many factors, including how aggressive a patient's myeloma is and whether or not it makes sense to wait for the CAR T cells.
mhm. So I know that waiting period can sometimes be quite prolonged, and as you mentioned, if a patient is really very ill, it can really mean that they just can't wait for that. So let's talk a little bit more about BCMA targeted agents and some of the nuances. So Jennifer, can a patient who had a stem cell transplant get a CAR T therapy?
Yes, they have.
So I know that sometimes patients get confused with, because when you have a transplant, you're collecting cells, and when you have a CAR T, you're collecting cells. So can you talk a little bit about like the differences between those two things?
Um, directed to Dr. Nathwani. Go ahead.
So, it's actually a similar process.
Hmm.
I would say we give, both CAR T cell collection and stem cell collection are outpatient procedures. For CAR T cells, generally, much quicker. You don't need shots to mobilize them. With stem cells, you require shots called GCSF to kind of push the stem cells out into the periphery. And then it's like a blood donation where you sit in this chair. You have your blood spin through a machine, and you separate out the stem cells, which you collect, freeze, and store for a future stem cell transplant.
Hmm. So, and it's a totally different type of cell, right, that you're collecting, right? So when you're doing the transplant, you're collecting stem cells, but when you're doing the CAR T, you're collecting T cells, right? And
Exactly.
they're
Yep.
totally not the same thing. So you can't use one type of cell for the other thing.
Exactly.
So, Dr. Nathwani, do patients have to be tested for BCMA expression in order to receive a drug that targets BCMA? Is there a connection there?
It's a good question. So, we have not been routinely testing for BCMA before giving a BCMA targeted drug for the first time.
Hmm.
Having said that, there may be some value in testing for BCMA expression if we are considering giving a second BCMA targeted drug if a patient has received BCMA targeted treatment previously.
Hmm. Yeah. So, and it's really interesting because there's a lot of work going on now to really look at the sequencing of different agents because there's so many agents that target BCMA. And the question is, if you have one BCMA targeting agent, can you then get a second BCMA targeting agent directly after that? And there was a quite an interesting presentation at ASH, which suggested that if you were a patient who had received a BCMA targeting agent, for example, for Tecvayli or maybe Blenrep, which is, it's also an antibody drug conjugate that targets BCMA, that if you then subsequently had a BECMA, that it wouldn't be quite as effective as if you hadn't had anything targeting BCMA before that, at least within like a 6-month period or something like that. So clearly this is something that a lot of people are working on and trying to understand a little bit better. So Jennifer, do patients have to be admitted to the hospital to receive these types of treatments?
We are doing CAR T therapy out as an outpatient. And as far as the bispecifics, we are admitting them for step-up dosing and with the goal of continuing as an outpatient.
Mm-hmm. Mm-hmm. And Dr. Nathwani, if a patient has a CAR T therapy and relapses after the therapy, can they then have the other CAR T therapy?
Yeah, that's a good question. So, yes, the short answer is they can get the other CAR T cell therapy, but we have very effective approaches using different targets. So, for
Sure. Mm-hmm.
example, there's a CAR T cell product using a different target called GPRC5D, and while it was a small study, the results were very promising with around 70% of patients responding. Just to clarify, both the both CAR T cell products that have been approved by the Food and Drug Administration target BCMA. So, GPRC5D as a target doesn't have any approved therapy as yet.
Mm-hmm. And that is the target of talquetamab, right?
Exactly. And
Right.
there are other targets as well, including
Right.
FCRH5.
Right. Right. So hopefully we'll see one of those new agents, one of those bispecifics that actually has a different target approved.
Yep.
And that I think would really help a lot of folks with this sequencing issue because you can target something different and then relapse and then target a second something different. So I think it'll be pretty helpful. So, Jennifer, as some patients may have multiple relapses, and as a result, they're treated with many different agents sometimes. So, some patients are considered to be heavily pretreated. does this limit the use of specific treatments? For example, maybe a patient's kidney function was diminished over time, or some other type of issue that was caused by prior treatments since they were diagnosed. And can that be a problem with some of these patients who are really very heavily pretreated?
When a patient develops relapsed myeloma, we consider several factors while selecting therapy. We will often use the mnemonic trap where TRAP, T for timing of the relapse, R is a response to prior therapy, A, aggressiveness of the relapse, and P, performance status.
Oh, I've never heard that before. That's a great one. I like it.
We also factor in patients' comorbidities and convenience, lifestyle, that's also a factor. Is someone able to stay near the CAR T center for up to 2 months? Does a person have a caregiver? Because we can't do CAR T without a caregiver. So there are a number of factors involved.
Yeah, a lot of factors that go into that. So, Janet, how do you handle your day-to-day since being diagnosed and the various treatments that you've had over the course of your journey? Have you had to deal with some side effects, and were they severe?
I've been pretty lucky in the side effect arena. Of course, stem cell transplant is, has the usual side effects that we all know. Probably the DEX has probably been one of the worst ongoing side effects, especially if you're at 40 milligrams. I learned early on that, I really had to watch my carbohydrate intake because apparently it affects how your body metabolizes carbohydrates. I've learned that, you don't fight the insomnia. You just have to take advantage of all that energy. And then when you crash, you have to sleep. With the talquetamab, I did have and I know it's listed as one of the side effects, but I had some pretty significant peeling of skin on my hands and eventually on my feet. And it was burning and it looked pretty bad. But Dr. Nathwani did prescribe an ointment for that, and I had ordered a big box of these disposable cotton gloves. So I was able to, continue. And to me, that's been important, is to be able to continue having a normal life, even though you have all these crazy side effects going on. We always seem to want to gravitate towards feeling like we can have a normal life. The CAR T side effects were just as what I'd read about, and Dr. Nathwani had, told me what probably would happen. I did get the CRS within hours of getting the infusion, so that was pretty fast. And high fevers, body aches, and then I had about a period of 24 hours where total amnesia. I don't remember anything, but pretty much once they give you the tocilizumab, it reverses things, and you start getting back to normal. Really haven't had too much in the way of peripheral neuropathy. From the very beginning, Dr. Nathwani had recommended B complex vitamins and alpha lipoic acid, and I really attribute that to that my neuropathy is very, 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 very minimal. I still get my quarterly Zometa, and I found that if they just increase the infusion time just a little bit, it makes a big difference on the body aches you get from it. And with the IVIG, I'll get that periodically if my IgG falls below 400. And not too much in the way of those side effects, although I have noticed recently, within the last 2, shortly after the infusion, I really start getting horrible nausea, and I'm not a nausea person, so but they give me the Zofran, and that pretty much takes care of it. So I don't know if it's the longer you've been on those drugs, the worst the side effects get worse, but I feel very blessed to have been able all this time to live a pretty normal life.
Mhm.
I'd say, I have a great support system with my family and my employer. I'm at City of Hope under Dr. Nathwani's care, so it probably doesn't get any better than that. And I've tried to do everything in my power to help myself. I really focus on healthy eating, daily exercise. I listen to visualization and affirmation tapes to, keep the positive thinking going.
So important.
It truly is. And I really am a firm believer in that mind-body connection. And you know, as Dr. Nathwani told me in the very beginning, this is, a marathon and not a sprint. And you really have to be in it for the long haul mentally, because you do go through so many ups and downs. You're up when the treatment's working, and you can get down when, it's not working. So you really kind of have to strengthen yourself mentally, kind of preparation for all of this.
Sure.
And, I've connected with a lot of other people in different myeloma platforms, people that are also 17p deletion, other CAR T cell people, other bispecific people. And it's been really helpful to be able to connect with them where they are along the way. And the administrator of these groups is very good about, we only share scientific type data that we can actually, it's not just our belief that this is why we think this is happening. And, for me, it's important to make plans. It gives me hope for the future, things to look forward to not feel like, I'm getting at the very end. And, that's why it's great to be at a center like City of Hope, where you have all these clinical trials available,
Right.
I probably wouldn't be here if it wasn't for that.
So it's certainly a very important piece of information that when you are diagnosed with myeloma, you really need to find a myeloma specialist to take charge of your care, because it's a very complicated disease. And in order to have the best outcomes, like you sound like you're having, Janet, you really have to be working with someone who knows all the best treatments and all the best new treatments, because there's new treatments around the corner all the time.
Yeah.
And that's what makes, being a myeloma patient these days so much better than being a myeloma patient like 15 or 20 years ago, when there were literally no drugs, right?
But it's amazing how many people aren't being seen by a specialist. They're just being seen by a general hematologist. And maybe they live in an area where they don't really have access
possibly
to a specialist. But, we always tell them, go find a specialist if you can find somebody somewhere,
At least, certainly, if you're a person who has a myeloma subtype, such as you, which does sound like it's a little bit high risk, right? Then it's extra specially important to find a specialist to help with your care. Because maybe if you have low risk myeloma or standard risk myeloma, then it's more or less kind of okay to be seen by, the hematologist down the street. But if you have a high risk form of disease, then it certainly behooves you to, at least, certainly when you're newly diagnosed, you should get several opinions, right, from different doctors. And one of them should be a myeloma specialist. And that way you'll know that you're going in the right direction. And even if you are seen by like a community hematologist, to be able to have that person consult once in a while with a myeloma specialist to make sure that what you're doing is really sort of keeping you on the right track. And Janet, you just sound like you're just a very resilient person to have sort of made it this far, right? With all the things that
I don't know if I just put my blinders on and did the Pollyanna dance, but
whatever it takes to just get through, right? So
well, and I feel like, because Dr. Nathwani is a specialist and he's been a doctor in myeloma for a long time, none of this is new to him. My cytogenetic abnormalities, extramedullary disease, all of that, he's seen it before. So that gives me a lot of faith in him.
Right. So you have confidence that you're seeing a person who can really help you.
Yes.
With your best outcome. So, which is great. So, So let's get back to our questions here. So, Dr. Nathwani, many patients realize that CAR T cell therapy may also eventually fail to work. And so, what types of options are available to those to patients who have relapsed from CAR T cell therapy? And I know we already talked a little bit about repeating CAR T cell therapy, which may work but may not, right?
Right. You know, excellent question. Fortunately, we have, you know, effective options even for patients who have relapsed following CAR T cell therapy. As we talked about earlier, both FDA approved CAR T cell products target BCMA. So it would make sense to try, a clinical trial perhaps with a different target. So, I would say I'll talk about two main other targets. Um, so one of them, as we talked about earlier, is called GPRC5D, and there are clinical trials with the CAR T cell product that I mentioned earlier. And there's also this bispecific antibody that we talked about briefly called talquetamab, which we're very excited about. It's not approved as yet, but there is tremendous excitement about this drug. So, Mary, as you talked about earlier, updated results were presented at our annual hematology meeting just last week.
Mhm.
And this particular treatment demonstrated an overall response rate above 70%. And
Wow.
even in patients who had received prior T cell redirecting therapy, the response rate was over 60%. So, these were very important findings, and so much so that they were highlighted again on the last day of the meeting at what is called the Best of ASH session, where the most impactful research findings are highlighted.
Hmm.
So an important thing to mention with this, GPRC5D target is that as Janet mentioned, it's expressed on keratinized tissue. That means your nails and hair follicles as well. And that's why it's fairly unique in some of the side effects that we see. The other target to talk about is called FCRH5. So this is also incredibly exciting. We've had patients who receive, who've been on this bispecific targeting FCRH5, and in one of the trials, this drug is given for a year. So that's also incredible that we have what we call a fixed duration of treatment. So we
Mhm.
don't continue the drug indefinitely. And I can tell you, we've had patients who have been off this drug for 2, 3 years now who are still in remission. So if a patient has relapsed following CAR T cells, as you talked about earlier, you could continue with the same BCMA target. And in fact, there was a recent presentation at our ASH meeting last week where a subset of patients in a small study who had received prior BCMA targeting treatment, including CAR T cells, still responded to another BCMA target, this time a bispecific antibody, and the response rate was above 50%
Mhm.
with the same target. It just,
Mhm.
this time it was a bispecific, and the first time it was a CAR T cell.
Mhm. Yeah, so I mean, you do see that. I had gone to some of those presentations, and if you have something that targets BCMA that you take before a CAR T, and a CAR T that would normally be maybe 70 or 75% response rate, will then drop to 50%. Right, but you still are getting a response, even though it's the same target. So I think that sort of sequencing information, I think, is going to become more and more important as time goes on. And the more targets we can pick up for these bispecific antibodies and CAR Ts, I think the better off all patients will be, because it'll be much easier to switch from target to target, and the efficacy should still remain, hopefully. But I mean, we'll see what comes out in clinical trials. You never know. So the other thing that we did hear about a little bit at the ASH meetings was the new iberdomide drugs. There was a presentation on mezigdomide. So can you tell us a little bit about that?
Yeah, absolutely. So, definitely there are a lot of exciting developments. So there's this, whole new class of medication, um, called cell mods, which bind to the same target as lenalidomide and pomalidomide that many of you are already very familiar with. But the big benefit is that this class of medications binds with higher affinity and degrades the target proteins much more effectively. So one of these medications is called iberdomide. And the very appealing thing about this medication is that other than lowering the blood counts, it doesn't have any of the other common side effects that most myeloma patients experience, such as fatigue, diarrhea, neuropathy. So the medication you talked about, mezigdomide, is in the same CELMoD class of medications. It's even more potent than iberdomide. We've shortened it to we call it mezi rather than
Busy.
mezigdomide.
Right.
So a very encouraging feature of this medication is that we have seen responses in patients with extramedullary disease, meaning myeloma outside the bone marrow, and we have a clinical trial using this medication at our institution. You asked about venetoclax. We spoke about this earlier. I won't go through that again in too much detail. Suffice it to say that we're very excited that we now have the ability to specifically target this 1114 translocation. Some other developments, allogeneic CAR T cells, meaning CAR T cells from a donor which undergo gene editing, are also in clinical trials, and these have the potential to be given to more patients and would not have to necessarily wait a long time for the cells to be manufactured.
Right.
And we also have clinical trials using allogeneic CAR T cells from a donor at our center.
Hmm.
And besides all of this, there are newer CAR T cells which are being studied that have been engineered to remain in the body for longer. There are also drugs called gamma secretase inhibitors that increase BCMA expression. And we also have a clinical trial using that at our institution.
Wow.
So
That's
there are a lot
exciting.
of new things coming up, that's for sure.
Yeah.
So, just out of curiosity, and I don't remember Paul Richardson talking about that when he was doing a presentation on Mezi, but is that an oral medication like Revlimid, or is it infused?
Mezigdomide is an oral
It
medication.
is oral. Okay. Okay. That's kind of what I thought. So, okay. So this has been a fabulous conversation. And I'd like to thank you all so much for being here with us today to answer all of these questions. So on behalf of the MMRF, I'd like to thank Dr. Nathwani, Jennifer Bautista, and Ms. Anderson for joining all of us today. I'd also like to thank everyone for taking time out of their day to watch this presentation. And finally, I'd like to thank Adaptive, Genentech, Janssen, Carrier Farm, and Takeda for sponsoring this session. If you have additional questions about what you have heard today, please call our MMRF Patient Navigation Center at 1-888-841-6673. Thank you again and enjoy the rest of your day.
Thank you very much.
Thank you, Mary.
Thank you.